So the title of my presentation was how I set up NAVA. Well, it's not really how I, but it's how we set up NAVA. And this presentation is not going to be rocket science, and I don't think anybody would care at this moment of the day. So this is really my personal opinion, and really how we did it in our ICU. So how we set up NAVA. So I'm going to touch on these topics. So what's the problem? But we have discussed that over and over again today, so that will be very brief. How did we do the implementation? What is the barriers that we were facing with the implementation? And finally, what is our current practice at this moment? Well, the problem is clear, and we can discuss whether it's important or not, but we thought that asynchrony is not good. So that was problem one, and the second problem has been touched upon as well, and that's this. I mean, that's the monitoring part. Erlen said it, I mean, we don't discuss monitoring any of these organs. We don't discuss monitoring any of these tissues in the ICU. We do that every minute, a couple of times a day, but not the diaphragm. I don't think anybody in this room is really monitoring the diaphragm, and it's so important. It has been touched upon today. I mean, a couple of years ago, there has been this landmark paper, New England Journal of Medicine, papers from our own lab. I mean, there's so much happening with the respiratory muscles while the patient is on the ventilator, while he is in critical illness. And we don't seem to care about it. We don't even monitor it. So that was for us a reason to think about the monitoring using the EDI catheter. Look at this. And it has been shown before by Paolo. This is just a patient recovering from pneumonia. 5 of PEEP, 12 of pressure support, nothing special. But there's complete inactivity of the diaphragm. And you can say whatever you want. But as a clinician, I want to know. I can decide to change practice. Perhaps that's not evidence, but to be honest, I don't need evidence for this, that this is not what I want. This is not the intention of supported ventilation. That's, again, my personal opinion. But without having the EDI, I just wouldn't know. The other thing here, other patient, nothing special. 8 of pressure support, 5 of PEEP. There's a kind of tonic activity of the diaphragm. I am not sure, no. I don't have evidence that this is bad. But from the little bit I know about muscle physiology, I can't imagine that this is good. If I can change my practice to another signal, to a normal, more physiological signal, do I need evidence that it is better? I don't know. So these are the problems, and that was the reason that we started implementation of NAVA and using the EDI catheter. So how did we do the implementation? We already had the servo I, so that made it a little bit more easy, of course, and we had it all with the NAVA software. We decided to buy 8 EDI modules, and we have a 35-bed ICU. That's cardiothoracic, neurosurgical, and medical and surgical ICU. And we had 8 EDI modules, including the cables, of course, and 2 different types of catheters, 12 and 16 French. And I think the most important thing when implementing something is get everybody on board. And one of the things to do is make a protocol. And that's what we did, make an easy protocol. A little bit of a background, a little bit of how it works, how do you do it with the catheter insertion, and a little bit of problem solving. And this protocol was discussed by the medical staff. Anybody could say whatever he wanted. But at the end it was approved, so we're going to comply with this protocol. It's available through the internet. And for anybody who wants it, it's translated in English now, so you can have it if you want to. So how did the implementation process go? We started out with workshops, half a day, just a keynote presentation, and after that, one of the staff members swallowed the catheter, had an inspiratory resistance, and just play a little bit with it. See what happens if you increase the NAVA level, if you decrease NAVA level. Just get a feeling of what happens. It's important to have workshops, practical workshops. We had separate workshops for nurses, very important as well, of course. And above that, we decided for every unit, I said we have 5 different units, for every unit to have 2 or 3 expert nurses. You don't have to train everybody into detail. They know how to do the practical things. But 2 or 3 nurses know a little bit more, a lot more actually, about the theoretical background. So if a nurse has a problem, she can ask her colleague. She don't have to ask her doctor, she can ask her colleague. And that's a good thing, I think. We had the booklets available, we had slide presentations available at the ward. And I mean, it's like Hans said, it doesn't make a lot of a difference, but if people are on a night shift, they can look it up, can see what they have to do if they have a problem. And important as well, but that's because we started out 3 or 4 years ago, we had the backup from McKay. We could call them. At that time, they had a lot of experience. So if we had any problems, we could communicate with them. How would you solve that? I mean, there are great people out there. Ask them if you have a problem. So how did we start out? Well, I think it's important, if you decide to start out with NAVA, start with easy cases. Start with patients who are a little bit forgiving. If you make a mistake, that you not immediately have an enormous problem. So not this kind of patients. In prone position, severe ARDS, these are not the patients to start out with NAVA if you want to do it at all. But these patients, it has been discussed so much today. Patients with obvious patient-ventilator asynchrony. So that's a patient with COPD probably. Patients who spend a lot of time on the ventilator. Patients who are going to wean from mechanical ventilation, like Unnen said. And this, I like it because you said that patients in need for monitoring, but I can't imagine what the question from Art is going to be. Which patients are in need for monitoring? So I think you are going to answer the question, okay? Very important. You can do 1,000 keynote presentations, but it's so important to get to the bedside. Go to your own patients. See if you have a problem. Like this. You have an EDI catheter. You have a patient on pressure support. There are the wasted efforts right here. What happens if I increase the level of pressure support? If I reduce the level of pressure support? I mean, that's interesting. I mean, you have discussions at the bedside with your own patients. It helps a lot. Well, this is another example. This is another example. So you have a problem right here. I mean, that's good with a couple of doctors, with the expert nurses. Just discuss what's happening here. See what happens when I change my NAVA level. See what happens when changing PEEP. I mean, you learn so much. And this, when there is a problem at night, you don't know what to do, just make a copy on this kind of memory stick, and so we can discuss it the next day. I mean, everybody learns from it. Mechanical ventilation is an issue again at the grand rounds. So, did everything go well? No, we faced a couple of problems during the implementation. And the first thing is that the courses were too complicated. I mean, the people in this room, I mean, we will have enjoyed all the physiology today, all the respiratory physiology, control of ventilation. But I'm afraid the people who are not in this room, they don't care. They are interested in renal replacement therapy, or they are interested in feeding or other things. So keep it simple in the beginning. They don't want to know about this physiology, and this is very hard for them. So accept that. Another problem. It's the chaotic breathing pattern. I mean, patients seem to be a little bit more agitated while on NAVA. They have a higher respiratory rate. And nurses and doctors were asking, what should I do? Well, explain them. It's probably just physiology. I mean, this is how we breathe. While we're here in this room, we have high and low tidal volumes. That's what we have with the patient on the ventilator now as well. And this is a problem, and Hans touched a little bit upon it. I mean, we are used to that if we increase the level of pressure support, respiratory rate goes down. You have to explain that this is not going to happen like that in NAVA. I mean, that's a way of part of the training. Tell them it works different. Probably the patient is fine. Okay, I'll skip this for time. And that's another important thing to accept. I mean, some patients fail in NAVA today. You can't just handle them in NAVA. Accept that. Don't fight the whole night because you get frustrated. Just switch to pressure support and see what happens tomorrow. But remember, you make the screen dump. So everybody can discuss, everybody can have an opinion the next day. I mean, these kind of patients, it has been discussed before. Patients with a very high respiratory drive, too difficult to get them on NAVA, probably. These patients, I mean, that's something we recognize right now. If there's an acute change in position of the diaphragm, either due to atelectasis or pneumothorax or whatever, you get these kind of activities. I mean, it doesn't get back to baseline, sometimes periods of tonic activity of the diaphragm. I mean, don't fight. Try to increase NAVA level a little bit, try to decrease it, try to change PEEP a little bit, but if it doesn't work, okay, switch to pressure support or switch to pressure control. I mean, that's how you would do it with pressure support as well. If it doesn't work, make a different strategy. Okay, so I've discussed this. If it fails, ask your colleague and take the screenshot and go to an alternative mode. And of course, this has been touched upon today a couple of times. It's the money, of course. A catheter is expensive. I mean, it's like 150 euros. But on the other hand, if it's in there for 10 days, 15 euros a day. I mean, we have an arterial line for blood pressure measurement. And is there level A evidence that it improves patient care? I don't think so. But we use it for monitoring because there's such a good rationale to monitor blood pressure in your ICU. So, okay, and the implementation is one thing. Sustained implementation is the other thing. How do you keep it going? It's training, it's updating protocols all the time. Discuss it in your staff. Make sure you have presentations by nurses and doctors about difficult cases. It keeps it alive, and communicate your success. I mean, if you're doing well, don't be afraid to tell. And we had it in the hospital paper. We even had it on our national news website. I mean, so that stimulates people to go on with it. So where are we now? I think, well, on average, we have 3 or 4 patients on NAVA. We now keep, that's what I said, continue to train the fellows, the nurses, and we continue to train the expert nurses. They go to conferences as well. Okay, this is how we do it in practice. The nurses have specific tasks, the doctors have specific tasks. I mean, it's clear for everybody what you should do. So what's the benefit? I mean, it's the point of discussion we will get to later probably. Did it improve patient care? Now we have been using it for 3 years. Did we reduce the days on mechanical ventilation? I think that's a very hard question to ask. I mean, in the last 3 years, so many things have changed in our ICU. We started out with early mobilization. We gave prophylactic haloperidol for delirium. I mean, so many things have changed. It's so hard to say if this strategy really improved patient care. Did it change sedation level? I don't know. Probably. I mean, we were a couple of people from Hong Kong yesterday in our hospital. We had a patient with ARDS completely awake on NAVA. She was really doing fine, completely awake. You couldn't do that on pressure control. So, and I think this is, well, I've told you a couple of times, we have more discussion on mechanical ventilation. It's more of an issue right now. And I think, well, it's a kind of interesting adverse event of this strategy. So, what's the lessons I learned from the implementation? It's not easy. Changing a mechanical ventilation strategy really takes a lot of time and effort. It's really not easy. It's really a teamwork. I mean, you have to get a lot of people aboard. You need the opinion leaders in your own hospital to put it forward. And communicate your success and, well, that's more a lesson for myself because I like this day, I like this conference, I like all the physiological background, but not everybody. So keep it simple for the other people. Okay, that's it. Thank you.